Cancer Council would like to acknowledge the traditional custodians, both past and present, of the lands in which we live and work. Welcome everybody. My name's Katie Towers. I am the Survivorship Lead at Cancer Council New South Wales, and I'm very excited to be bringing you our webinar on how we can live well with advanced cancer. So we're going to be covering what it means to have advanced cancer and some strategies you can implement to support yourself in living well as well. Regular viewers may notice a bit of a change with our layout. It's all a part of a new webcast platform that we've introduced, which has better functionality and a tidier look. I'll explain the functionality in a minute as well. A reminder that this webinar is being recorded. Everyone who's registered will be sent the link to the recording. So don't worry if you get distracted by the chat box, you will be sent a link at a later date. And for the first time, thanks to Dry July, we're also streaming live on Facebook and our online community. So if you're watching us from those platforms, please feel free to link through to the registration page to join us on the webinar platform. So let's get started. Firstly, I'd like to introduce our panel. Please welcome Ian, Craig and Di, who have very generously taken time out of their day to contribute to tonight's session. So thank you very much, all of you.
Thank you. Thank you.
We also have Laura, who's going to be manning our chat box on the webinar platform. Siobhan and Jill will be manning the Facebook comments. And Kate is also going to be overlooking the online community posts. So feel free to say hi to everyone there. We will have time for questions at the end. So feel free to pop in some questions in the chat box and in the comments section. However, if you do have any medical specific questions, it's best to have a chat with your health professional about that. And just a quick note on the chat box and the comments on both Facebook, online community and the webinar platform. Please take advantage of it being a comfortable and safe space for you all with your peers, but also please respect each other's views. There will always be different views and experiences, and allow each other to contribute and to the conversation, and please do not take part in any inappropriate discussion. If at any time you do need to speak to someone urgently, please do not hesitate to contact Lifeline on 13 11 14, where they have counsellors available 24/7. Okay, so just on the new webinar or webcast platform. So this is specifically for those who have registered and are taking part on our webcast platform, not so much on the Facebook and online community. So this is all about what you see with the icons at the top right of your screen. So that green one, that shows all your slides. So see what's coming up and see what the rest of the webinar looks like ahead of time. You have a chat box option, and that will come up with a separate window. So, and please do use the chat box. Let us know how you're feeling. If anything's relating, was the information useful to you? And are you actually going to take into the strategies as well? The blue icon. So we have put together some resources specifically for this webinar. So that's also available in the resources in the blue button. That will also be sent out to you after the webinar. And then the yellow icon is the exit survey. So this is where you'll have an opportunity to provide some feedback on tonight's webinar. And again, this is specifically for those who have registered and in the webinar platform. The red is all about notifications being read, and that's where you'll get all the alerts and announcements that might come up as well. And one of my favourites is the map. So you get to see where people are taking part and watching the webinar all across the world. And we do have some international people taking part, which is always exciting to see. And of course, if you need any help, if you can't hear or if something's gone wrong, you've got the live chat which you can take part in. You've got some FAQs in that bit as well. But if you do need some really quick support, just give that phone number a ring and they can help you out with some tech support. And then there's the additional information just in the right-hand side that you might want to have a look at as well. Okay, that's enough for me. So first up, we're going to move on to Ian Kant, who is here to tell us about his story with advanced cancer. So there you go.
Thank you. Look, Dad, I'm on the internet. G'day. Hi, everyone. My name's Ian, and I'm here today because I have sinusitis. It's a true story, but I'll get to that shortly. Okay, I'm a Hunter Valley boy, born and raised, along with my two brothers. I'm the son of two cancer victims. My mum passed in 1995 at the age of 52 from ovarian cancer. My dad had colorectal cancer about 8 years ago now. We're about to celebrate his 82nd birthday in a week or so. He now tours the world spending our inheritance. I'm a father of three and part of a Brady bunch of 7 all up. So I was born about a bit over 2 weeks before man landed on the moon, a month before the love-in that became known as Woodstock. The irony of my birth is that I came to life at the Mater Misericordia in Waratah at Newcastle, the very institution that has and continues to take care of me to this day. It's now being known as the Calvary Mater. I'm a retired detective with the New South Wales Police Force. I served almost 20 years in various roles. Had the opportunity to investigate sexual assaults, armed robberies, major drug task forces, several homicides. These included 2 triple murder suicides at East Gresford involving the entire family. And then at Oakhampton Heights, where I was the first officer at the scene and subsequent investigator of the incident where a mother had killed her husband and 2 infant children with a shotgun. Before committing suicide, my marriage also broke down. Maybe there is some good to come from this. The reason I mention this tonight is to help to show that all of us have individual stories, and it's true of all cancer patients. Each patient's cancer is not only different, but the person who has the cancer is different in themselves in every way. So as a result of my experiences, I have an exceptional dose of diagnosed PTSD, and all of you out there tonight are here for my group exposure therapy, so thank you. Since my retirement, I've retrained myself through practice and study, and I started a small building company. Now, back to my sinus. In November 2015, I had an MRI and they found out that I had sinusitis. So my doctor gave me a referral my GP gave me a referral to go and have a chest x-ray to rule out bronchitis before going and seeing the surgeon. So I did what every typical male Aussie does, and I put the referral in the door pocket of my ute. So that stayed there over Christmas, holidays, people coming and going. And finally I was driving down the main street of Maitland one day, and I was driving past one of the x-ray centres there, so I called in. And I had a chest x-ray, and as I was leaving, the young girl who took my x-ray asked me if I had another appointment with my GP. And I said, yeah, I've got to go back and see him about the sinus. And she said, oh, okay, no worries. I thought it a little bit odd at the time, but that was 11 o'clock in the morning. By 2 o'clock that afternoon, I was sitting in front of my GP being told that I had a 66 millimetre tumour on top of my left lung, and that I probably had either lung cancer or lymphoma. So as I said, I visited Dr. Lightbody, my GP, he's Dr. Lightbody, and I was straight in for a bronchoscopy with lung specialists at the Mater. Now to telling my family, I found that half the battle with cancer, a cancer diagnosis for me anyway, it really is making others feel okay around you. People don't know what to say or ask. I learned to let other people approach me, to be open and honest and answer all questions, no matter what they are. When I was diagnosed, Dad was in Queensland holidaying and came home. Our older 2 boys kept to themselves, being a little bit naturally introverted. My youngest are twin boys. They're big Star Wars fans. And at the time, when I'd wake up, as it progressed, I developed a small wheeze when I wake up of a morning. So they named my tumour Darth Wheezer. They told me that I didn't have to go to any of my appointments anymore, as they call it, as they were going to cut it out with their lightsabers. It was quite cute. Demi, my daughter, wrote me a poem Sorry, guys. It was about my sickness and how she saw it through her young eyes. To this day, it's one of the most beautiful things I've ever heard, particularly knowing it was about and for me. The first 3 weeks in April 2016, I was in and out of hospital. I was visiting lung specialists, undergoing numerous tests, blood tests, biopsy scans. I had a pneumothorax when I had a biopsy through my chest, one of the most painful things. The results come back and they confirmed, all of them confirmed, that I actually had melanoma. It was full-blown, stage 4, metastatic, indeed potentially terminal melanoma. So on the 23rd of April in 2016, it was a Saturday night. It was the Saturday night of the Anzac Day long weekend. I received a call from who became my oncologist, who's with the melanoma unit at Newcastle. It was an introduction to the unit. He told me to no longer drive as they had found a tumour the size of a golf ball in my cerebellum at the back of my brain. He had already organised everything during the next week for my treatment and for my brain surgery. Okay, this is a PET scan of a person with cancer. To all you medically qualified people out there, I'm sure you know what you're looking at. To all the non-medically trained people, let's suffice to say that the previously mentioned group just said a collective, oh shit. That PET scan is me. That's the 66mm tumour on the top of my left lung. There's somewhere between 20 and 30 other tumours throughout my lungs. There's 2 on my upper abdomen, and my entire lymph system was inundated with melanoma, as well as the one in the back of my brain. Now, not starting from a very good baseline, I became very depressed, selfish, angry. I stayed in bed. I talked to Parso, a mate, he's a retired detective as well, and now works for the Cancer Council in Newcastle. A lovely bloke. I had an epiphany in the form of my partner at the time, now wife, Anne. I was in one of those moods in bed, and she walked in, I thought, with a cup of tea and to fluff my pillow. And she leaned over and she said, Canny, everyone calls me Canny, she said, Canny, get up, you stink. So it worked. I realised I just had to get up. On the 4th of May 2016, I had brain surgery to remove the golf ball-sized tumour from the back of my brain. That was an amazing experience, once again to do with modern research. They located it by GPS and it was incredible. Then to my first face-to-face meeting with my oncologist. Ian took me from the John Hunter while I was there with having brain surgery and returned me afterwards. We'd previously spoken of several drug trials that were about to begin that may suit me. I told him of my interest in these. One of the required criteria for the trial was that I was either 8 or 12 weeks, I can't remember, I had to be 8 or 12 weeks clear of brain surgery. And I said that I was happy to wait. Now, I've seen and heard some pretty horrible things during my time, but this is the point in time that you think will never happen to you and words that you'll never want to hear. My doctor replied to me that I couldn't afford to wait that long. So my drug of choice became pembrolizumab, or Keytruda as it is known. It's an immunotherapy drug. I then had after I'd had the operation, I had targeted radiotherapy to my brain from a temple all the way around the back. I lost my hair, it was quite humorous for my kids. And I lost most of my taste. I probably should have gone some chili eating competitions. I think I would have done quite well at that point. And then since that time, I went on to have, it was 17 or 18 pembrolizumab infusions over the next 12 months. Every 3 weeks I had them. And I had scans every 3 months during the course of that. So now this is a CT scan of someone without cancer. Wouldn't it be great if there came a day that cancer patients got to have scans like this? That day is here for a few. That scan is also me. So that's what red wine and cannabis can do. No, I'm only joking. The doctor still insists it was my immunotherapy that achieved that result. Okay, so as you can see on the top of the left lung, which is on the right-hand side of the screen, there's a small scar there left over from where my immune system did the job on the cancer. A couple of farts down the bottom, I think, ready to go, I've been told. I think that scan was taken about 6 months in. It could have been the 3-month one, I'm not too sure, but the drug did work for my immune system pretty much straight away. That scan remains, my latest one was a couple of weeks ago, and it remains, and indeed it's even better today. So I now spend some of my time as a consumer in research for academics, and I speak to all about my experience in order to promote immunotherapy and research. I still have my struggles, particularly with living in what are now 6 monthly periods I'm out to, those being between my scans. I still get antsy around that time, particularly because of my PTSD. But this was my story, and as I mentioned, each patient has their own. I think it's important to see the whole person, including from before the beast arrived in their lives. I want to say thank you to my family who went through all this with me, and indeed still do. A particular mention to my now wife Anne, who has not just been through but lived this with me every day. I love you so much. Okay, I now carry this symbol with me for 2 reasons. The first is to show what I think of not only the people who helped me, but all those who dedicate themselves to researching, treating, and in any way helping someone with cancer. You are all super people. The second reason may not be known to some. In the DC universe, where it comes from, the symbol's real meaning is hope. At this point in time, I'm one of a very lucky few who have reached this complete response point in treatment. But that allows me to stand here tonight to prove there is hope, real hope. And that comes from new treatments, from clinical trials and research. Something that these guys here, you're about to hear from with me tonight, are really good at. Thank you.
Thank you.
Good.
That was
Thanks,
amazing. Thanks.
Yours.
So we've got Craig, who's up next. So it's all yours.
Great, thank you. Thanks again for the invitation to come and speak. Ian's story is an amazing story, and I've heard it before, so thank you again, Ian. And I guess what we're going to try and do tonight is really try and be quite general about things, because everybody's story is different, and I think that's one of the key points that everybody needs to take away, is that your story is very individual to you, and you need to interpret your story in the context of all the information you have, and then with the healthcare professionals that are looking after you. So I don't have a disclosure slide tonight, but we are often offered additional support and funding from industry and pharmaceuticals groups, and I've made a very careful decision early in my career, guided by my mentors, that we never accept any of that money. The money certainly goes to other entities, charities that we work for, other people that we do voluntary work for, but we never accept the money ourselves. So I think that's a crucial point. So but I don't have a slide tonight. So advanced cancer, it can return or it can arrive. So some people might have had a primary cancer, like a breast cancer or a bowel cancer, even lung cancer, and you might therefore know a surgeon or a radiation specialist who will be looking after you and will be there to guide you, and may certainly be the person who indeed might tell you that a cancer has returned. And that's not obviously a happy situation, but it's slightly happier than the unhappy situation of a cancer arriving, and certainly Ian's story reflects that, where the sudden shock of going along having sinusitis and having to just get a chest X-ray when you remember, and suddenly being told that you have advanced cancer. So the paths and the experiences of people who have those two kinds of situations are obviously very, very different. So that's one of the first things that's going to determine the difference between people's outcomes. And just to give you a flavour of how challenging this can be for potentially for the healthcare professionals that are looking after you, here's a little example. So here's a person who might have had a bit of a cough or some breathlessness, and they once were a smoker, or maybe if they've been exposed to asbestos, they might have got a bit of fatigue. And their family doctor may organise a chest X-ray, and that may then lead through a pathway to considering the diagnosis of a lung cancer. The animation's failed there, unfortunately. What I wanted to show with this slide is that that is just a really small slice of an enormous number of possibilities. So you can have a very simple set of symptoms that can then transform and indicate a cancer or another illness. And so one of the experiences that people will say, well, I had this cough, and then it took the doctor weeks to find out what was going on. Well, a cough could be anything. And so the animation was to show that there's an awful lot else going on there. So that's the thing, is that advanced cancer can be hard to sort out. So you may need a biopsy in the first instance. You may need blood tests or scans. And then you may need to be referred to a specialist to understand what all of those pieces of information mean. And again, Ian's story exemplifies that. So one of the ways that you can learn to cope with that is becoming the expert on you. So on your smartphones, and most of you will have a smartphone, or most of you will know someone who comes to your appointments who has a smartphone, you'll find an app on your phone that might look like one of those buttons that's a voice recorder or a voice memo. And you can just ask your healthcare professionals, your doctors, permission to record the consultation. And I routinely suggest this to my patients, and particularly if I'm going to blabber on for 25 minutes and tell them, all of the things that I'm wondering about and the options that they've got, it's useful to listen to those again. The other possibility is a smartphone app called Can Recall, and it's developed by some really talented people here in Sydney and licensed out by Rare Cancers Australia, that is both a recording but also a prompting. So it's got a bunch of questions that you might want to ask if you meet an oncologist or your surgeon. So it's a very useful app so you can get that through the app stores. The other thing that's really important is you've got to remember that everything needs to be taken in context. So this is the old allegory of the blind people and the elephant. So if a blind person walks up and feels the elephant's trunk, they think it's a snake. If they feel the side of the elephant, they think it's a wall. If they feel the ear, they think it's a fan. And so everything needs to be taken in context. So the broader thing is keep calm and don't Google it, because what you might find out or what you might know when you go to Google, you'll get very generic information. And so again, everything's got to be translated back to you in your context. If you are diagnosed with an advanced cancer, then obviously treatment is one of the questions. And one of the first questions you need to ask about treatment is why. What's the goal of the treatment? Can the treatment be something that can potentially cure the cancer, or is the treatment something that will control the cancer? Will it control it for a short time or a long time? And what kind of treatment? Would it be tablets? Would it be injections? Would it be chemotherapy, targeted therapy, immunotherapy, or radiation is still very useful, and sometimes even surgery? Where will the treatment be given? Is it going to mean lots of trips to a hospital? Can you take the treatment at home? When? So you'll need a calendar, and that's where your smartphone comes back in. How will it be delivered? Will you need to be in hospital to have those infusions? And who will give it? Will it be the nurses who are giving it, or are you able to take it yourself? And again, what can each treatment do for you? So you might have a treatment that is focused on preserving your quality of life and controlling the cancer and the cancer symptoms, making you comfortable, making sure that you can carry on living a comfortable life and enjoying the life that we all must leave at some stage, but you want to keep it for as long as possible. Or are you looking for a treatment that can do something like this? And those are nobody scans. Those are scans that I've stolen off the internet, images I've stolen off the internet. I'll be honest, but that's obviously a extraordinary case of a situation where someone might have had a cancer and has had a dramatic response. And that's the dream that we have as healthcare professionals for people. And occasionally we can be part of the delivery of that, but all too often we're not. It's what we strive for, but we're still working as hard as we can to try and get there. And then what price is the treatment? So again, this is, had the reference on the slide there, but we had, this is again some work from a group in Sydney who did a really nice study looking at the experience of people taking chemotherapy, in this case cytotoxic chemotherapy, for a variety of different cancers. And along the bottom is time, and up the graph is the number of people at any one time or who've developed that symptom over time. So chest pain, for example, is not a common symptom reported by people with cancer taking chemotherapy. Constipation is a bit more of a problem. Maybe they don't have the farts to get out. Breathlessness, depending on the situation, seemed to be a problem, and particularly towards the end of people taking 6 months of chemotherapy. And fatigue, although if you ask all of us in the room, 2 out of 3 of us will say, I'm feeling a bit tired. So how much of that is modern life and how much of that is related to the cancer and how much is the treatment. So you've got to understand what kind of price you might pay for what kind of benefit you might get from a treatment. And it's certainly got to be a balance. And again, individual results may vary. And so it is all into the context of you and the treatment and what it may or may not deliver for you. So look, this is a tool that I've developed. I'm sure I've stolen it from someone. I probably didn't develop it myself. I've just probably stolen it from someone. But if you think of it as a way of a matrix, comparing the benefits of the treatment with the treatment side effects. So the benefits of the treatment, maybe 50% of the people here will get a benefit, and a proportion of people here will get a side effect. Obviously, everybody wants to be in that box there. It's inconvenient having treatment, but you've got a benefit and you didn't have any side effects. That's a box that you really didn't necessarily want to end up in. The treatment's helped you, but you're paying a price in terms of side effects. That's the box of meh. Nothing much happened. You didn't get any side effects, but it certainly didn't help your cancer. And of course, that's the worst possible outcome, where you're getting all of the side effects and none of the benefits. And this is the balance that you, as an individual, need to make in context with your family, on the advice of your healthcare professionals as to what each treatment can do for you. So obviously, we really try and avoid treatments like this. Sometimes we find ourselves under a lot of pressure to give a treatment, and we might predict that this is what someone will experience, and we really try very hard to argue against that particular kind of treatment. And of course, this is what we're all striving for. Nothing's perfect, but we want the best possible with the least side effects. So look, here's a couple of examples. I'm privileged to work for people with prostate cancer, men with prostate cancer, and we often offer a hormone tablet to take on top of hormone injections in a man whose prostate cancer has spread to their bones. And, the treatment can help, and it's light green there because it's a temporary treatment. It works often for about a year, but it can help most men with these tablets, and the chance of meaningful side effects is actually quite low. So this is a nice treatment. It can often help. It doesn't cause a lot of grief, but it starts to run out of puff after about 12 months. Severe side effects occur in some people, but most people will just get some annoying stuff. And I think that's not a bad treatment to recommend to people, knowing that, but having to promise that unfortunately it'll run out in about a year. This is actually the kind of treatment that Ian's described. So this is immune therapy injections for people with advanced melanoma, which help about 4 out of 10 people. And they help them. I've made it dark green there because they help a lot of people really a lot. And it's very binary. They either fail people completely or they give a really great result. And we are so deeply grateful to see those treatments because Di and I both practiced before these treatments were invented, and we certainly felt very powerless in the face of this cancer without these treatments. Side effects, I warn people, will occur in 2 out of 3 people, and in 1 out of 6 people will be serious side effects. So, you may well like to run that gauntlet for that kind of benefit, but again, individual results may vary. So what about clinical trials? Ian alluded to that, and I may talk about it a little bit of that as well, and I'm certainly very passionate about it, and we've got an incredible healthcare system in Australia that enables us to actually think about this and add this on to our standard of care treatments. So a clinical trial is something that tests an idea, a drug or a device in terms of healthcare. And it asks for people who are volunteers, but it also, we need to reflect that they're people in situations who didn't necessarily want to be there. So there's a lot of pressure on people in that situation. So we try and be as delicate as we possible as we're describing those treatments. It could be to prevent a cancer or prevent an illness, detect an illness, diagnose an illness, treat an illness, or focus on the quality of life. So you can have clinical trials that do all sorts of things, and that's again a question to ask if you're offered one of these things. The clinical trial might be useful to you. Of course, that's the promise for people with advanced cancer looking for a treatment, that it might be useful to you, but it's really important that we never promise that it will be, because that's the point of the trial. If we knew that it was going to work for you, it wouldn't be ethical to run a clinical trial. It's always a situation where we have something called equipoise, where we have a belief, but a belief that needs to be tested, that a treatment might be useful. But it must be informative for future people. We shouldn't do trials unless we can actually use the information from the trial to answer questions to inform future people. And when I talk to people about this, the common thing that people will come up is, well, I'd like to take this clinical trial because I know that all of the treatment options that you're offering me as a standard were proven by other people behind me who've taken those trials. So it's certainly a very humbling enterprise for us to take part in. Clinical trials are not compulsory. They can be offered to you, but you don't have to take them. Sometimes the concept of them is too foreign for people. That's completely fine. They're not irrevocable. If you make a decision to take a clinical trial and you want to stop, then of course you can. They shouldn't be more expensive than your current treatment. They might be more visits to hospital, but in the benefits of the overall wonderful Australian healthcare system, they shouldn't be a lot more cost to you. And they shouldn't be something that we think of as a last resort. They're often the best first option to consider for a treatment, in particular in cancer in this day and age. Joining a clinical trial guarantees you'll at least get a standard therapy if it's a first treatment, and it may well give you an opportunity to take something even more exciting. And again, they're not something of desperation or last resort. If there is a placebo, there are still clinical trials where there is a placebo. That should be the situation where no treatment is proven to be beneficial in that situation. So, for example, in the adjuvant setting, where you might take an extra treatment as an insurance policy after a surgery. But at best, at least you should be taking a standard care. So the placebos are offered in some situations, but that would be in the case where you wouldn't ordinarily offer a treatment to a person in that kind of setting. And again, that's mostly in this day and age, in the setting where people have had a surgery, successful surgery. There doesn't seem to be any cancer, and we're wondering whether or not an extra treatment will stop the cancer from coming back. Now, the other thing that's important, I think, and it's useful to ventilate this in Australia, because we're fairly laid-back people and we don't like to necessarily tackle the hard questions, but don't be afraid to ask the hard questions about what this cancer means for you and what it means for your life and what will happen. And, obviously there needs to be a balance between ignorance is bliss and fortune favours the prepared mind. But I would argue to you to tip the balance to learning a little bit more, because, if you've got some knowledge, that means power for you. But of course, this is again something that's individual to you, that you will need to make a decision that's right for you about what you want to know. And certainly when I start to explore this with patients, I sort of start to say, well, what would you like me to talk about? And one of the things that people fear, and occasionally sometimes they still get attached to, is they get told that they might have X amount of time to live. And one of my mentors taught me about Yogi Berra, not Yogi Bear, but Yogi Berra, who was a famous baseball player for the New York Yankees, who has all sorts of quotes misattributed to him, but this is one I think he probably did say, and it's very difficult to make predictions, especially about the future. And it's really hard to predict what the future will hold. So I think that any time, you shouldn't be afraid to talk about those things, but should take everything with a grain of salt. The other thing to potentially confront and talk about is, to talk to your family about what you might want. So, this is the idea of, if you were in a vegetative state dependent on a machine, if that ever happens, just unplug me, okay? So, you don't want to be dependent on some. Hang on. Oh no, sorry. You don't want to be dependent on a machine. A little joke here, turning off the TV. But if you face healthcare decisions, if you face health problems, then you may find yourself in a situation where you can't speak for yourself. And if your family knows who you are and what you want out of life, then they can be really well informed to advocate on your behalf. You can do that formally with things like advanced care directives. You can do that with medical power of attorney, and that's certainly something that can be done and is recommended, but at least talking to your family is really important. So the way I like to sort of approach this is to say to people, look, it's useful to get all that paperwork done, and then just don't worry about it. It's all done. Then you can rest assured that all of those issues are sorted out and you're not leaving any trouble behind. One of those particular points is having a will. So if you don't have a will and you pass away, if you die, then you're in a state that's called intestate, which sounds vaguely obscene, but trust me, it's a really difficult situation for your family. Your family then embarks on a game of snakes and ladders with the appropriate legal authorities in whichever state you reside in. It's different in every state, different in every country, and generally it's a giant mess. So at least having a last will and testament is a way of making sure that your wishes are well documented and that your family's sorted out. So don't leave them to roll the dice. The other thing that tends to happen in this context is that the oncologist suddenly becomes a really important figure in your healthcare team, but one should never forget your family doctor. They're just as important as ever, and they're actually probably more important than ever. They continue to look after you and your community. They'll continue to provide help with all your needs. If you've got new symptoms, if you need pain relief, they're the ideal person to write a prescription for a painkiller. You don't need to wait to see a specialist in an ivory tower, in 3 weeks' time. You should go down to your local family doctor who's been looking after you for a long time anyway. So it's really important. They are as important as ever. And there are many other people in the healthcare team. So the cancer care nurses or cancer care coordinators are absolute gold. They are the glue that sticks our hospitals together. They know who the services are, they know how it works. And if you find yourself in a cancer stream without a cancer care coordinator, it is painful as a healthcare professional, and I can't imagine what it's like to be a patient who's facing that situation. So the first thing you should do when you walk in the door is don't ask for the doctor, ask for the cancer care coordinator. Psychologists are really valuable because this is a really big challenge that you're facing, and getting some headspace around that is really valuable. Social workers can help you with the nitty-gritty if you need it, and of course pastoral and spiritual care are really important as well. So that was my last slide. I just tried to give a run over of a whole bunch of stuff that you might face if you're facing advanced cancer and trying to live with it. And thanks for the opportunity.
No,
Hand over to Di.
So just before we do, I've just got a couple of questions that have come through. I might link one of them up to both of your presentations. Heather wanted to know, Ian, how did you go with the treatment and to correlate with the lovely side effects slides that you were showing, and the joy and the meh bit and the severe side effects? So how did you go with your experience?
Yeah, I was in the green box. I had very, very few symptoms. I had a small amount of psoriasis on my knees and on my elbows, but we got through that okay with a bit of topical treatment. And, after the ray, obviously I lost my hair, and the taste was, it was the worst part of it was the ray therapy. Going through that, but certainly the immunotherapy, whilst I do understand a lot of people do have some severe reaction to it, I was again one of the lucky ones.
That's good. Thank you.
Right.
And just, Craig, when someone's looking for a clinical trial where's the best place that they can go to that may not be their oncologist?
Yeah, so that's been a constant problem internationally, and it's being solved temporarily, but I believe that there's a more permanent solution coming. There's a couple of websites, so clintrial.org.au is one of those at the moment that's really focused on smartphone apps that can go onto your phone, that are suitable for each state. I think Victoria's got its own one that's separate, but most of the other states have got got an app on the clintrial.org.au. That's being rolled into a national service for all kinds of clinical trials. It actually rose out of New South Wales, out of some of the haematologists who figured out that they needed to be able to let everybody know what clinical trials they had so that people at different hospitals could take opportunities. So you certainly should ask your oncologist and ask around, because if you take even one dose of a treatment, you can become knocked out of a clinical trial. The problem with clinical trials is that sometimes they're very, very stringent. You know, are you a rugby league supporter? I'm terribly sorry, this trial's not for you. It's only for AFL supporters. So do look early and look often.
Thank you. That's great.
So true.
Guy, you're up.
Okay. Well, again, thank you also for letting me come and join the group. So, just in case anyone has not yet submitted any questions, I think really this is an opportunity to talk about any hopes, fears, or facts that you would like us to help you with in terms of living with an advanced cancer. And I think what's come through everybody's talk is really that everybody's experience is different. And so even though you might be the same age as someone or have the same type of cancer, and you may even be on the same treatment, your experience compared to somebody else can be very, very different. And that's because we're all individuals. And I think it's very important that that's always upmost in our minds. And I would just say that when we see people in clinic, when we think about how we can look after people with advanced cancer, it's really trying to give them treatments to control the cancer. So ultimately, if they have symptoms, they feel better. And hopefully, if they don't have symptoms, that we give them treatments that's not going to make them feel too unwell. So it goes back to Craig's diagram. And really, at the moment, for many cancers, if they're advanced, we can't cure them, but we can usually treat them sometimes for a long time. And I think what's really good, it's showing my age, but over the past 15 years as a consultant, the number of new treatments that have come through that have been able to help control cancers for longer is just massive. And I think for some people, these cancers actually can almost be viewed as a chronic disease. You have to be on treatment to stay well, and usually, provided the treatment's relatively well tolerated, it is that concept of a chronic disease. So very much coming back for treatment, coming back for clinic reviews, but life hopefully can carry on and not too interrupted by your treatments. And ultimately, my hope is always that we can try and keep people as well as they are physically and emotionally, and really trying to maximise that quality of life. And as Craig talked about in one of his podcasts, there are some cancers that we can actually just watch for a little while, and really we try and get the feel as to what they're doing. And for some people, we don't have to treat them for a while. And particularly, as Craig said, with kidney cancers, sometimes we can actually just watch them, get a feel, get a sense of the biology of the cancer, and then sometimes we do have to step in and start treating. But not every cancer has to be treated immediately, but sometimes, yes, they do. That example of you being phoned at Saturday night is an example of someone that needs sorting out pretty quick. So amazing to have that kind of oncologist. I think what I wanted to show with the sunflowers is that they change over the day where they face. And I think the important thing is when you're having your treatment and what you experience with your cancer, that changes, and so do your needs. So how you feel and what you need will change with time. And it's very important you're open with your doctors and your care team as to what your needs are, because you can't assume that everything's all static. And I think probably the biggest part, I think in terms of either being diagnosed or dealing every time, is feeling a bit like you're setting up camp in the dark. You really don't know what the future's going to bring. And so when you pitch your tent in the dark, you may not know whether you've pitched next to the river or not. And hopefully there's no croc nearby. But I think it's helpful for us to actually shed a bit more light. And so if we can actually provide a bit more support, we could actually change that experience for you. So I think that's why these podcasts have been really good, because they actually have shown that if we actually support you, we can actually do a better job at changing the experience that you're having. And so we talk about supportive care. It's an umbrella term that goes underneath all the treatments that you could be offered. So there are some people who have every treatment there at some stage in their treatment, but some people may have just had surgery or just had chemotherapy. Some people may have just needed radiation, others being on immune therapy, or these things called targeted therapy that can either be injections or tablets. And what the supportive care does is actually try and keep people living well with the cancer while they're having the treatment. And the big thing about supportive care is actually under this umbrella term, the palliative care service. And ultimately, I'd like it rebranded. I think that it's very difficult to refer someone for palliative care when people feel that that's being referred for end-of-life care, and that's not what the service is always for. And I think it's very difficult to refer someone when they're called palliative care. And I have to spend probably about 5 minutes explaining why I need support from the palliative care service to help look after people, because I can't come out to you at home, but I know that the community nurses can come out and see you, and they can ring me if things are not going quite so well. And so I think it's really important to understand that palliative care, even where I work, is palliative care service, but they provide supportive care. And I have people that have been looked after, and palliative care has stepped in and stepped out of their lives, and for 2 years haven't needed the support of palliative care, but it is just really important. So we all feel, and it's really great to see that the podcasts have talked about this, about could we perhaps consider rewording what palliative care is into more supportive care. So it's not always that if you're referred to palliative care, does that mean I'm dying? So it's a big no. But it is a difficult thing, and I think around the world, the difference between palliative care and supportive care, I think everyone's having difficulties with what the groups should be called. Ultimately, it's basically so you can see the best professionals for your symptoms, and you receive holistic and multidisciplinary approach. And ultimately, what we want to do is reduce the burden of symptoms related to the cancer as well as the cancer treatments to maintain your quality of life. Because if you're benefiting from the cancer treatment, you might be able to stay on the treatment for longer if you're being supported, which then can increase how long you live with the cancer and how well you feel at the same time. So if your pain's better managed, you may be able to tolerate a bit more treatment, and you might be able to get a bit more treatment in, and then actually be able to be treated for longer and actually live longer. So I think it's really, that's where supportive care comes in. And, as Craig said, we do live in a blessed country. That's because he's a Kiwi. I'm not allowed to say that on national television, am I? But it is about increasing...
Another blessed country.
Another blessed country. It's about increasing the likelihood that, you know, you may be able to benefit from future therapies that may come on the PBS in the future. So they may not be quite yet, but if we can keep you well enough, we might get there onto the new treatments, or to get onto a clinical trial that then could become a breakthrough. So I think that the bridge analogy, we were talking, Craig and I, about metaphors being very powerful, and I think supportive care can help get you to further treatments, and it also allows you to lead the life you want to lead alongside your cancer. So that's about living as normal a life as possible. I've just seen a lady today who's 82, who's gone back to tennis, who's actually got metastatic cancer in her bones, and she's gone back to tennis. And I think that that's incredible, and she's very happy. So she's enjoying her friends. They're probably not enjoying her being back on the court, but anyway. And she's, you know, it's about finding meaning in your life and trying to stay as well as possible every day. So supportive care can help with pain, can help with nausea sometimes, which can be a little bit trickier than a typical Maxilon can help. Can help you with fatigue and sometimes feeling that breathlessness that you might feel, or emotionally distressed. And so who provides supportive care? Now, your GP is so important. Your GP knows you inside out, hopefully, and if not, go find one that's going to get to know you, because they become so important in helping you. And ultimately, your cancer specialist, whether that's a medical oncologist, a radiation oncologist, sometimes a surgeon, they are quite busy cutting, but that they can provide a lot of supportive care. And then the supportive palliative care teams. But in addition, you've got a raft of people. You've got social workers, psychologists, the dietitian, exercise physiologists, physiotherapists, care coordinators, lymphedema and massage therapists and acupuncturists, and then always the Cancer Council. So I think being aware that you can ring for support, and sometimes at a time of need, that's just absolutely fantastic. So it's pretty much everybody's role to help you. It's not just one person's, and I think it's really important that everybody does feel it's their role to help you. And sometimes at the same time, so sometimes you need a sort of village of people to help you, and then they'll step in, step out, and then you can say goodbye to some of them if you don't need them anymore. So you can be a little bit selective about who helps you, but there's lots of people there. And I think it's really important, this goes back to what Craig was saying about when you've got your little voice recorder, is trying to make sure that everything you're having the discussion with is sort of explained and shared, and it's a shared decision. It's not just made or told to you, and that you've actually got the time to sit down with your doctor, explain the how, what, why of what treatment you're having and perhaps what the alternatives are. And so I think having the recorder to try and remember what the alternatives were so you can go back again. And then if you're thinking about trying to plan how your life's going and, you know, could you take that holiday and get out a calendar so you can work out, you know, can you have a short treatment break or what can you do? And so you can work backwards. And I think that's very, very helpful. And it really ultimately it's about building trust, trust with your team. So through open communication so that you know that you've got a reliable port of call. And ultimately, many GPs will build up a care plan. They'll try and identify concerns, and so will the supportive care teams. And as much as possible that it be evidence-based. And it's trying to give you a new sense of self at a time when things have changed dramatically and trying to work out how you want to live your life. And if possible, use your GP to do this. Now, the next part of my talk is my favourite part because I actually am part of a group that we're trying to promote exercise into cancer care. So unfortunately, all my registrars in clinic, they get to hear the spiel all the time. But in actual fact, I want what's happening on the right-hand side when I'm looking at the slides, which is exercise. It doesn't have to be hardcore full-on weights, but it can be any form of physical activity, should become part of cancer care. So it's not just surgery, it's not just treatment, it's not just radiation. And so if exercise was a pill, we would all take it because if we know that exercise can improve your energy levels. If you do go for a run, you get that buzz back feel at a later time. So if you go for that walk, you do feel better. You've got air in your lungs, get to see some nature. Hopefully your dog doesn't cross the road and eat a burger like mine did the other day, because that's quite stressful. And then you can build up your muscle mass. You can reduce your stress levels apart from the dog crossing the road. And then the important thing is that sometimes it means you can get more treatment in because you're actually less tired. And you may be able to have more treatment and therefore control your cancer for longer. So ultimately, the most important thing is we know it is actually safe to have during and after treatment. And where possible, I'd encourage you to have a chat with your doctors about what kind of exercise could be prescribed for you. I think the important part about exercise is that we now know it should be prescribed like a medicine because not all exercise is the same. So if you're very, very fatigued, it might be different to the kind of exercise program where you're trying to build up some muscle mass again. So like a medicine, you've got to work out what type of exercise, how hard you do and how much. And so where possible, you need to not go and see Joe, the personal trainer. You need to go see someone who's actually got some experience in exercise for patients who have cancer. And so ESSA is an accredited group. They are the Exercise and Sports Science of Australia, and they've brought out a lot of documentation, a lot of guidelines to help patients, and they have to be accredited to be able to be funded by your GP for an exercise plan. And you can get 5 for free from your GP, provided you're not using it for your podiatry. And I think that's really, really important because it's a great start to get that confidence, to feel safe, to do a bit of exercise. And I would say that Cancer Council has done great things in terms of helping our patients because they actually provide us a program called the Enrich program. And I've had patients with advanced cancer who have been stable. So a lady of mine who actually has ovarian cancer for the past 5 years, which is advanced, but she's been through the Enrich program. So if you are stable relatively well, but this kind of program can really support you. And all the patients that have been through these groups, because I've actually been to the sessions, they've become friends with each other and they've actually built and strengthened relationships. And I would say that even if you think actually you don't have any energy, I would actually potentially say that, and I think this is an Australian expression, but I don't know because I'm a hybrid of England and Australia these days, but they say that it's like picking off the lowest hanging fruit, that if you've actually got more fatigue, you actually benefit the most from a little bit of intervention with the exercise. So even that's just another minute extra of your walk every day, and you can build it up, build it up. It's not about trying to exercise massively and then get an injury and then not benefit. I'm just going to say one thing, which is that if you exercise and you build up your core strength, you could be like the flamingo on the right. Whereas unfortunately, if you lose your core strength and you're on a chemotherapy that might cause you a neuropathy, you might slightly overbalance. And so the fear that I have for patients who are on chemotherapies that make them sometimes get tingling in fingers and toes is not just that symptom, it's more that I worry about them risking having a fall. So I actually talk about having that core exercise to help people. So I think just that analogy, apologise to anybody for calling them flamingo. Look, if possible, we would like people to stop smoking. I actually celebrate if people can just cut down. I would be, very wrong to say that that's going to be an easy thing for anybody with a diagnosis of advanced cancer. But you may feel a lot better. And I think for some cancers, we actually think that it can actually promote the cancer growth. So we know for melanoma that it potentially can increase the risk of it coming back if it's been cut out relatively early. And so quitline can help people. And we just have to acknowledge that it's sort of a relapse-remitting kind of problem because it's addictive smoking. And it is important to think about your nutrition. What you eat does influence how you feel. And I think that where possible, trying to cut down on red meat for colorectal cancer is important, eating vegetables. And if you're going to think about taking any herbs, that you should discuss that with your doctor and the pharmacist, because the pharmacist can do a cross-check, making sure that nothing affects your treatment, because you don't want anything to make it more toxic or actually not work as well as it could do. And some of the evidence of using some of the supplements is relatively limited, but some is a little bit stronger. So I think it's just important to cross-check with what treatment you're on and what cancer you have. And look, that's not a party pooper, but just to say where possible, try and reduce alcohol. You get empty calories from alcohol, but I've definitely said that people can have a beer with their tablets of various different descriptions. So I'm not saying you can't have a drink, but where possible, just remember that sometimes it'll detriment you in that way. So there are all these other questions, the who, what, why questions, but I might leave the questions to you out there. Thank you.
Thank you very much, Di. So just on that, we are going to be sending out the resource list, which will have all of the programs and resources that you guys have talked about as well. And of course, where it all stemmed from, which was the podcast, The Thing About Advanced Cancer, which is an amazing new podcast series that has been released. So we are now just going to ask a few questions. We are going into overtime a little bit, but please stick around because there are some great questions to be answered. The first question that's come up is something that I'm sure comes up a lot, is how do I explain to my family and friends the best way and what it means to have advanced cancer without them going straight to that, absolute worst side of it? You all have the floor. So what do we think?
I think, from my point of view, as I said earlier, I allowed people to come to me because it became confronting for them. It was very difficult for people to come, obviously because they love you and they're worried about you and they don't know how to ask that question. And from a patient's point of view, it's different to having the flu, you know what I mean? And I was just open and be honest, and if you're comfortable with doing that.
Yeah.
I often observe that it's a bit like a hurricane. The person with the cancer is in the eye of the storm and relatively calm and often, all right, this is what I've got and this is what I've got to do. And it's the people that love that person that are spinning around them at 200 kilometres an hour. So it can be extremely confronting and stressful. Again, I think this is where a recording of the consultations with your healthcare professionals is valuable, because you get to reflect on that yourself and reflect on that with the family, and it opens up all of the topics for that discussion.
And even just hearing it back yourself as well, and hearing what it is exactly what happened, because you can zone in and out as you go through the session, I'm sure, as well.
And I think sometimes people also just wait a little bit before they've got a bit more information to start discussing things. And I think that there's no harm there, because sometimes if you're not a bridge of the whole picture, it's a bit difficult to try and explain what's going on.
That's right.
So time can sometimes help as well.
Which I think kind of leads well into what is the difference between the advanced and metastatic and progressive and all these different words that people hear when they're going through the diagnosis stage.
And I think the broader question is that as much as oncologists try to communicate well, we're often under time pressure, and we can see the number of people in our waiting room, and sorry everybody who's waiting in my waiting room, and you know, you want a cup of tea and you want to go home and see your kids. So sometimes you do use jargon and buzzwords. So it's never a problem to stop and ask people to explain things again. And again, for example, those three words effectively mean the same thing.
Yeah.
So advanced and metastatic are effectively the same thing. Metastatic is just the medical term. Progressive is really the question of if you've got an advanced cancer that's starting to grow despite whatever treatment you might be on. So, but you know, relapsed, recurrent, you
Yeah.
know, all of these things are sort of just
All those
buzzwords, right? That we unfortunately use.
That's great. Very good. Thank you. And I think one of the very popular topics that come up recently is, so has medicinal marijuana been researched on its curative effect on breast cancer?
So just like you can make a medical textbook that costs 300 times as much by putting the word medical in front of it as a textbook, this is a problem we have at the moment. That by putting the word medicinal in front of marijuana, we're giving it this incredible power. Just like every other treatment, we need to put these through clinical trials. And so Di and I are actually being part of a clinical trial that's run by some really talented people here in New South Wales, where we've tried to test whether or not cannabis can actually help people who are suffering nausea during chemotherapy treatment. But it's really one of the first randomised clinical trials that we've actually seen with this disease. And I'm certainly trying to work with the very newly born medical marijuana industry, but they again don't quite know necessarily what they're doing. And we've got this enormous amount of belief in cannabis as a treatment, as a supportive care. And I don't know about you, Di, but I sort of say to people, look, it's certainly, if it gives you a sense of well-being, if it helps with your sleep, if it improves your appetite, if it doesn't cause you any major symptoms, well, how am I to deny you that? But is it actually going to have an effect on the cancer? Well, I've got this beautiful clinical trial that I'd love your support for. $1.5 million, we'll get it done. It'd be great.
Crowdfund.
Right. What's your approach?
Yeah, I think that we just need more evidence, and the difficult part is that getting funding for clinical trials to prove the evidence is what we need. Because whatever we do try and recommend for people, we try and base it on knowledge, and trials are the only way to get that knowledge.
And I guess the corollary of that is that this is not to say that all of the medical therapies that we're using, you know, necessarily have the most robust evidence. And in fact, sometimes often we're left in a situation where we don't have a good evidence base to advise someone. You know, you've had a treatment for your cancer, it's come back, what's the next treatment?
Yeah.
You know, again, we need to test all of these ideas, and we've got to figure out better ways of doing clinical trials in order to do that. So this is not to disparage cannabis, it's just really it's just one of the other things that we just need to do a lot of clinical trials on.
Yeah, that's good. Thank you. I think the last question there is about how people maintaining jobs. We did talk, you showed the slide earlier about all the side effects that individual results may vary, different with everybody, but just maintaining that, trying to maintain as living well with your advanced cancer, as the webinar is called. And how do we do that when you're living with these side effects long term? I mean, Ian, do you want to?
Yeah, look, I certainly had some time off. I was off the road anyway for driving purposes. I did have a mate who'd come along and pick me up, and I just sort of chat with him for the day, you know, so that sort of kept my mind off things. I'm in the lucky position where I'm self-employed. I think somebody who's employed by the man, it would be in a they are in a completely different position. The social implications, particularly with relation to living with advanced cancer now and how long we're living and how much better, and potentially someone like me that this mob beside me don't like what I call the C word, the cure word. I think that's just one of the social implications that there are. And it goes into your finances, it goes into your superannuation, getting it out straight away. It goes, yeah. So it's certainly, I couldn't give you a direct answer. It's certainly from my point of view, that's how it went. But it's a massive area that has to have something done about it. Some research put into it, some time by governments and put into it.
Yeah.
I do find the support from the Cancer Council. There's a booklet called Cancer Work and You, which I often refer to. And in there, it's actually got support, because a lot of my patients who are on treatment, sometimes their employers, surprisingly, sadly, sometimes they have a friend or a relative who's actually been through cancer and they're quite supportive, but occasionally somebody may not be very supportive. And so the booklet's brilliant, because at the back you've got help, and it actually can show you that actually you shouldn't be discriminated against. And I think it's very important, and social workers actually come into their element in terms of helping people at that stage, because you're quite vulnerable, and it's like, how much do you tell on your employer and stuff like that. So I think that's really helpful.
Thank you. Thanks. I'll move on just next. We do have a lot of questions, but we are going a bit over time. So I want to talk about the support and information that we've kind of touched on throughout. Cancer Council in 131120. So there is so much support and information. If you've got any questions that may have come up, Monday to Friday, 9 till 5. There's also our website where we have a whole range of information, all the booklets and PDFs, and even things like position statements, legal and financial fact sheets when we're talking about wills and power of attorney, whatever it may be. Just go check that out and give 131120 a call. There's also a lovely online community which we are streaming live onto tonight with Kate. There's everything from online blogs and forums and support groups, and all the resources there as well. From everyone who may have been just diagnosed, or maybe they have advanced cancer, or they're a carer, or the family member, or even friends who can join and have a chat and really just let out all the information and get some support from your peers that way as well. And again, there's Lifeline on 131114, which you can call 24 hours a day for telephone support crisis. And they've got online services as well, so you can just go through to that link and get some more information. Okay, so just a reminder, we do have the exit survey, which will be available to those who've registered to the webinar when this closes in a minute. And those who have taken part of on our Facebook and online community, thank you very much. It's been a first for us, and I'm hoping it went really well. I'd like to really, really thank our panel, and it's just been the best night tonight, and I really appreciate your knowledge and your experience, and it's just made the night that much better. So Ian, Craig and Di, thank you very, very much.
Thank you.
And thank you, Laura, Siobhan, Kate and Jill out there in the chat box. Hope it's all gone well, and also thanks to Dry July for supporting us and making us being able to go out into Facebook and the online community. So here we go. Please take the 5-minute survey. Thanks, guys.